Right, welcome everybody. Today, our special speaker that's invited is Dr. Carla Pieterman. And Dr. Peterman and I have worked quite extensively over the years together. So we are on first name terms. So I'm going to call her Carla. So Carla is currently an endocrinology fellow at the University of Utrecht in the Netherlands in the Department of Endocrine Oncology. And that is at least until February, but we'll come on to that a bit later. She's a clinician and a researcher, although these days she is much more involved in research and doesn't particularly see patients. So back in 2018, her PhD dissertation was on the long-term outcome of MEN1 related manifestations. And it's safe to say that she has had an interest ever since in MEN1 syndromes. And that includes being, and this is not an exhaustive list, but being the coordinator of the Dutch MEN study group and the multi-centre clinical biobank, a member and driving force of the European Neuroendocrine Tumour Society MEN1 Task Force, and a member of the writing committee who've been updating the international MEN1 clinical practice recommendations. So safe to say right now, I need to just make sure you're aware that despite her latter role, Carla is not here to talk about specific guidelines or clinical practice recommendations today, just guidelines generally. So thank you very much, Carla, for joining me today after that long introduction of just a small amount of what it is you've been doing over the years. So lovely to see you and to speak to you.
Thank you, Jo, and thank you for this wonderful introduction. I'm really looking forward to our talk and happy to be here. It's a joy to work with you, as always.
You're so polite. Right, so first questions first. Could you give us just a sort of a general overview of what medical guidelines actually are and how they're used most commonly in clinical practice?
Yeah, so if you boil it down to a very short definition, medical guidelines are evidence-based recommendations for daily practice. So if we break that down a bit to the components, it's for daily practice. So what do they cover? Guidance for day-to-day patient care, usually within a specific topic, such as a certain disease or a certain treatment or a certain procedure. You have guidelines for treatment of pneumonia. You have guidelines for how to use bone densitometry measurements, things like that. For whom they are intended, usually the primary target group of these guidelines are the healthcare professionals seeing patients within that specific topic of the guidelines. But they are certainly also used by patients, allied professionals, and they are certainly regarded by other stakeholders, such as policymakers, for example. Then going to the component of evidence-based, well, this means that recommendations are based on research outcomes. And the word evidence-based is often contrasted to the word expert opinion-based. And that means that recommendations stem from the experience of experts in the field. However, I have to say that all guidelines do involve a certain amount of expert opinion, even if they are completely evidence-based. So it kind of depends on the evidence, how evidence heavy a guideline is, but we'll come to talk about that later probably. And important other thing to mention is they're usually intended for daily practice in a specific setting. So for example, if you look at diabetes, you could have guidelines for the primary care setting, but also guidelines for secondary care or hospital setting. And you would expect these two settings to be different and to be needing different recommendations because the patient population is different, but also the type of care that is provided is different between these two settings. Yeah, so that's kind of a breakdown of medical guidelines are evidence-based practices for daily practice.
Brilliant, thank you very much. And I suspect this is going to be a complex question to ask, but can you give us an idea of how guidelines are developed and sort of maybe probably as long as a piece of string, but how long does this process take?
Yeah, well, exactly. Yeah, it is a kind of complex question. But you can break it down to several elements. So first is you have to start the guideline development. So who generally initiate this? It's often professional societies. So, for example, in my line of work, endocrinology, it could be the European Society of Endocrinology or globally the Endocrine Society. But especially in rare diseases, you may also have guidelines development initiated by research or expert networks. So large examples of this are the ENDO-ERN, so the European Reference Network for Rare Diseases, could initiate guideline development. Another example from the endocrine field is the NSAT, the Adrenal Network, which can also initiate guideline development. And then in a whole other ballpark, you have government organizations or organizations like the WHO, or in the UK, for example, the National Institute for Health and Care. Excellent, nice. So any of these parties can initiate guideline development, and they will set the topic where a guideline is needed. So when you kind of have that start, you need a committee or a working group to develop these guidelines. And what type of people would you usually have in these working groups? Important, you would have methodological experts who know about how research is done and how to judge quality of research. You would have experts on the topic that the guideline is about from the different disciplines that are involved in that specific topic. Patient representative, very important, and it's mandated now in all organizational guidelines that patients are part of the working group for guidelines. And sometimes you have other stakeholders informed as well. And also be happy to jump in if you have any additional clarifying questions along the way.
Yes, I mean, I guess it takes potentially somebody who is interested in a particular disease at some point to say to a medical society, we need this, or are the medical societies, do you think, keeping on top of what needs to be updated and when?
Yeah, so the medical societies would generally, from their public and from their working groups, establish a priority of where guidelines are needed or guidelines need to be reevaluated. And if you have, especially in the rare topics, you do need those kind of professionals that care and that push the development of these guidelines. Absolutely. Yeah.
Yeah. Okay. So you mentioned evidence there as well. What sort of evidence do you need to develop a good guideline? So perhaps, for a rare disease maybe, or
Yeah.
particularly it's difficult, I think.
So if we go back to the development, when you have the topic and when you have the working group that's going to work on it, then it usually starts with formulating clinical questions where you want to have recommendations on in your guideline. And then the literature will be systematically searched and recommendations will be formulated based on the outcome of that literature search. And there are established methods for doing that. One of the most common methods is the GRADE approach. That's GRADE, and that stands for grading of recommendations, assessment, development, and evaluations. And it's kind of a transparent framework where you can develop and present a summary of evidence and also a systematic approach for making clinical practice recommendations. So that it's really transparent and clear what the foundation is for a certain recommendation in your guideline. And after these clinical questions are developed by the working group, the literature is systematically searched. And what do I mean by systematically searched? Is that before you actually search, you start with determine what are the search terms, which type of research will be considered relevant and will be included in the final review and will indeed be part of that foundation for the recommendation. So to give you an example, if you would have a clinical question pertaining to primary hyperparathyroidism associated with MEN2, for example, and you would do a literature search. You would stipulate in advance that you would only include studies in your review that are about MEN2 patients. If there's a study about MEN1 patients with primary hyperparathyroidism, those studies won't be included in your review because it's not relevant to your question. You would also look at the type of research that was done. So another example, if you look at thymic neuroendocrine tumors in MEN1, you may conclude that you don't want to include studies that are case reports only, where 1 or 2 cases, exceptional cases, are presented, because that's not a good way to base your evidence on. So all that is established upfront before even the actual search is done. Then the literature search is done, and then the studies that are found are appraised for their methodological quality to help how reliable the conclusion of that study is. And then for all the studies, data are extracted and pre-specified outcomes are combined, and then the recommendations are based on these results. So going through that, what you would need to build these guidelines on is that there is research on the topic. There has to be research, but the research also has to have a certain methodological quality to base your evidence on. Because when you finally make your recommendations based on literature, they receive a kind of level of evidence, and that is the certainty that you think the conclusions of all this evidence are really, really true. So a very low evidence is that you think, okay, all the studies have found this, but we have very low confidence that this represents the real thing. And if you have a very strong level of evidence, then you think, okay, this is what the research says, and we have confidence that this really is true. So what you would need to make those guidelines is a combination of, you have to have research on the topic, and it has to have a certain methodological quality. Now, coming back to your question on rare diseases, it's often, rare diseases are rare. So often for good methodological studies, you need a certain number of patients to detect an effect. And it may be difficult to get enough patients to do high quality studies. The other thing is that in rare disease research, it may be difficult to obtain money to do certain research. And contradictory, there may actually be more money needed to do rare disease research than a common disease. Why? Because you have the logistics of needing to work together with multiple centers internationally, transatlantic, and to establish all that collaboration actually would make study efforts more expensive to get high methodological quality. So that's definitely a challenge for rare diseases and guideline development in rare diseases. Oh, and then back to the timing questions. Then when you have all that put together, the guideline committee will make the final recommendations by consensus. Then you need to write a paper, and then it often needs to be reviewed by external experts, by committees. And then you finally have to put it to a paper for publication. So up until that stage, it is not seen by the general public. So this process, you can imagine, takes anywhere between 1 to up to 3 years to complete.
And this is on top of all the other work that anyone who's involved is doing, either clinical research or both. This is an additional job on top of all of that that's presumably unpaid as well.
Especially for the clinical experts, so they have clinical duties on these guidelines development. It is next to their other duties. They're depending again on the resources available and whether it's a societal organized guideline. You may have methodological support provided by the organization where it's a job where actually people work on it, that it's part of their job to help with guideline development. So it kind of depends on the setting, but especially the clinical professionals that are involved in guideline development do this next to their other duties.
So I suppose there has, is there a slightly different method that can be used for rare diseases when there's just a dearth, a complete lack of evidence, as we've seen in some diseases?
Yeah, exactly. And there definitely is. I mean, and that's what we were talking about in the beginning when you say a guideline development is evidence-based, and that's often contrasted to expert-based, although realistically it's more a combination of the two. But in case of a rare disease where you have limited amount of evidence, you can still do a literature search, but then you see you either have very few or studies or methodological low quality. And in that case, it may rely more heavily on expert opinion, and there are methods available that make expert opinion more quantifiable and transparent. And one of these methods is the Delphi method, which is also used in the upcoming MEN1 practice recommendations, but also, for example, in the recently published UK guidelines for pituitary tumors in children. And in that process kind of starts with the literature review background. And then several statements around the topic are developed by a core group. And this is then sent to an expert panel, which can respond to these statements with either agree, disagree, not answer, and provide room for remarks. Then a certain percentage of agreement will usually mean the statement is adopted, often around 70 to 80%. And other statements are then developed into a second round where the same occurs. So that in those first rounds, the individual experts that make up the expert panel answer all these questions individually, and the core group compiles everything. So it's important that that expert group, that expert panel that you ask, is large enough so that you know that if you add 1 or 2 or 3 experts more, it probably won't change the composition of the answer. So if you have like 2 experts in the expert group and you ask 2 others, the chances are that your conclusions will completely vary from the 2 to the 4. But if you ask 50 or 54, the chances that your conclusion will differ are much, much smaller.
Yeah.
Another point to remember is that an expert panel needs to be made up of those disciplines that are relevant for the topic. So if you are doing a topic that involves an operation, then you probably should have surgeons on there, which sounds like an open door, but still. And then when you have those individual rounds, then there's usually a final round where the entire expert panel comes together, either digitally or in person, to discuss all those recommendations and also get the interaction between experts. And of each of those individual rounds, the results can be tracked and reported and be very transparent. And that can then lead to final recommendations.
And we've seen in some guidelines that some of these recommendations are indicated through, 1 to 4 spots or cross X's in zeros and that sort of thing. And so that's indicating the actual strength of a recommendation. Is that right?
Yeah. So you have and that's kind of from the grade approach. You have a level of evidence that shows how certain are you of this evidence, and that's those bullets with those crosses in it. So you have 4 of them, and if you have only 1 of the 4 ticked, it's very low. If you have 2 of the 4 ticked, it's low. If you have 3 of the 4 ticked, it's moderate. And that means that when you get to moderate, that means that you believe that what you find is probably close to the true effect. And if you get to high, that's 4 out of 4, usually in those bullet systems, then it means that the authors have a lot of confidence that the true effect really is what they show. So those bullets are the level of evidence and how certain you are that a particular effect is true. So if I say I have treatment A and treatment B, and the outcome of my literature review is that treatment B is twice as effective as treatment A, and you have it with 1 bullet, 1 cross, that means that the authors believe that although all the studies have shown that treatment A is better than treatment B. The true effect might even still be the other way around.
Right.
So that's kind of what very low evidence means. And then as you go progressively up, there's much more confidence that the effect really is what the evidence suggests. Now, based on that evidence, the recommendation will be made, and then you have the difference between a strong and a weak recommendation, and that takes into account the level of evidence, but also the costs and all other things surrounding a certain recommendation. A strong recommendation means that it is, in most situations, this really is the best course of action. And in most cases, you should undertake this action. A weak recommendation means that in most cases, this is a good course of action, but there really may be multiple situations where this is not the right course of action. So that's...
I guess that can actually guide future research projects as well, can't it? Because if there's low recommendation, you know, maybe the expert centers will look and go, perhaps we ought to actually gather some evidence on this, and that will help with the next guidelines. Or
Exactly. Those points that are really weak, those are the areas where further research is needed.
Yeah,
absolutely. Yeah. Yes.
So they can be sort of open to interpretation a little bit if the evidence is relatively weak, I guess. Yeah.
Yeah, and then oh, sorry, go ahead.
Yeah, no, because I think, you know, patients generally are much more aware of guidelines now and are referring to them because they're generally open access as well, and they're told about them by their clinicians and other people as well. So, I mean, how would you explain perhaps to a patient that the guideline doesn't fit what treatment they need, or why a clinician may need to deviate from a guideline in the treatment of that patient?
Yeah, and I think it's a combination of a few things. Guidelines are important because they're professional standards, and as a professional working in healthcare, you should abide by professional standards. But as we just discussed, the strength of these recommendations in guidelines may differ. So if you have a weak recommendation, that means that this may not be the best option for your patient in your circumstance. And you can discuss this with the patient and explain and say, in most cases, this is a really good option, but there are other options also. So, and then you go discussing what is most important for you? What outcome is really, really important in your daily life? And you go through the shared decision process where you say, okay, but if these outcomes or these situations for you are really, really important, and we have this strength of recommendation and this evidence that is weak, then perhaps in your situation, we shouldn't follow this path, but go to another path. And the reasoning is different when you have a really, really strong recommendation. So where you say, okay, in almost all cases, this is clearly the best course of action medically because the outcomes are better. Still, there can be situations that you need to deviate because as a medical professional, your job is to provide the best care for an individual patient. And guidelines can never give exact recommendations for one individual patient in all their circumstances. So it's often still the general patient, and you know as well that there is no such thing as a general patient. Another very easy example is this. If it is recommended that you do an MRI for a certain diagnostic procedure, and this patient has a pacemaker that is MRI incompatible, then it's your professional responsibility to deviate from the guidelines saying that you need an MRI, because that's going to be a problem for the patient. So that's a really, really, really simple example of how to when you should deviate. So it may be your duty to deviate from a guideline at some point.
Yeah, absolutely. It's it's eternally fascinating, but also I guess, when it's taken so long to develop a guideline in some cases as well, by the time it's published and people are made aware of it, perhaps things have changed even then. So I guess that might be the case.
Absolutely, and that also there the medical your professional responsibility comes in as well. So if the guidelines have been published and after that there's major new evidence, it is your responsibility to consider, judge, and implement this in clinical practice, even if the guidelines are not yet changed.
Yeah.
And for example, if I look at the situation in the Netherlands, the national guidelines that are currently developed by the Federation for Medical Specialists, they have changed to go to a modular approach, where each guideline is divided in several modules that are adapted and changed on a modular level instead of changing and adapting the entire guideline. And the reason for that is that the module change, you can see which module has new evidence that's completely relevant right now. And if you only change a module, it goes through a much faster timeline. So you can do it within a year. So you can stay much more on top of the actual evidence to move forward.
Well, that sounds like once again the Netherlands is streets ahead in doing things like this. Definitely, that sounds incredibly sensible, and I hope that's something that other countries can
Yeah,
adopt.
and I'm not aware, I have to say, I'm not aware of the situation in all other countries of guideline development. So many other countries may have implemented this already, but that
I'm,
it stems from the observation that you make that it takes
yeah,
so long to
yeah.
develop that in the meantime, other evidence might emerge.
Yeah. Oh, it is, like I said, it's infinitely fascinating, the whole area of guidelines, and I'm sure you're going to be very sad to leave that whole that whole world, of 3 year long meetings to
Yeah.
produce guidelines, because we know you're moving to a new role come February
Yes,
at the
absolutely.
National Cancer Society or the Dutch Cancer Society. So
Yes.
do you want yeah, so tell us what it is you're going to be doing. It's very
So,
exciting.
so I'm moving to the Dutch Cancer Society, and that's a charitable foundation in the Netherlands that funds cancer research. And what I'm going to do is I'm going to be the coordinator for their data biobank and research infrastructure program. And that's kind of establishing where the priority should be and how we can support and push a research infrastructure in the right direction. So it's a big shift, but also an incredible chance and opportunity to use the experience I've gained in patient care, in research, to
Yeah.
be able to help improve future research.
Well, like I said to you before we started recording, you've contributed such an enormous amount to, in particular the MEN1 community, but the MEN syndrome community as a whole anyway. And it's been such a pleasure working with you over the years. And I hope that we still touch base occasionally and catch up on what you're doing, because I think it's going to be equally valuable. So thank you so much for everything you've done, and particularly today for joining me and talking about guidelines. And I think it's going to be very useful for everyone. Thank you so much, Carla.
Thank you so much, Joe, for the invitation. It was a pleasure to be here as always, and absolutely should we keep in touch.